I think there's some disturbance in the audio as I can feel here. I'm sorry for that. I'm just trying to figure it out. I'm sorry for this error. But in case my audio is clear, please let me know, okay? I think there's some disturbance in the audio as I can feel here. I'm sorry for that. I'm just trying to figure it out. So is the audio clear, guys? Please message me in the group. Yes, guys. So audience is looking at the audio. I feel that it's quite better right now. I'm just checking it out. So the first question here: a 17-year-old male presents with complaints of delayed puberty. There is reduced facial hair and gynecomastia. On examination, he has small firm testes, tall stature. Yes, guys. So audience is looking at the audio. Yeah, tall stature along with a sparse body hair. Now, this question is pointing towards there is patient having academically below average but has mild learning difficulties. So what do you think is the most probable chromosomal analysis possible here? Hi Saichand, yes, I think it's okay. No, it's not recorded here. Hi Saichand, it's not recorded. It's alive. And over very sure results will be out. Hi Crazy TSP, the audio problem not. I think now it's clear, right? Saichand, don't get so much irritated by small things that happens to your life. I think you should have a positive approach to everything that you can have. Okay, not live, not live. These are not the things that you should say in open media, and you should understand what issues can happen. But I'm very sure that you will be finding this very important and early session, and you'll be able to diagnose the cases and can also help. This session will surely help you to understand the questions that can actually come up in the upcoming next year as well. Okay. So first question, what do you think is the answer? There are a few important things that you should note in the question here. One is a delayed puberty, reduced facial hair and gynecomastia is there. There's firm testes, tall stature and the long limbs with the sparse body here. This whole history is pointing towards what is referred to as a Klinefelter syndrome. Okay, Klinefelter syndrome. This is a Klinefelter syndrome. Now since it's a Klinefelter syndrome, it points towards a 47XXY, right? Now the question is, how should you remember a Klinefelter syndrome? I'll tell you personally how I remember this. So how I remember this as, since there is a Y chromosome, the Y is means a male, right? And with the Y has an extra X. So because the Y has an extra X, how I remember this as, this extra X causes the problem in the small testes. Okay. Now, if you can somehow remember the small testes, a lot of things will come to head. Why? If the testis is small in size, the first thing you should remember is it's a decreased testosterone, and hence estrogen-testosterone ratio should be high. Correct? If this happens, the patient can have gynecomastia. Okay, gynecomastia. Along with that, because of testosterone, the patient have a decreased secondary sexual characteristics. Okay. Along with that, there's an increased LH. There's an increased FSH. These are two other things which can happen in such patients. Okay. Along with that, the patient often have a long stature with a long legs, and this refers to a eunuch-like body proportion. Remember, the patient have low mean IQ, but they do not have cross mental retardation. So this is a basic feature of what is called as Klinefelter syndrome, and hence the answer is 47XXY. Okay, what is an XXY? So very good. Crazy TSP. I would prefer a better name, but thank you. Okay. So the following is a pro-apoptotic gene. What have you marked for this, all of you? Guys, what have you marked for this as an answer? Yes, the answer is pro-apoptotic, means it should be BCL. When you get a letter L, L is a anti-apoptotic, correct? So if any gene does not have a letter L, it becomes pro-apoptotic. So pro-apoptotic actually includes the BAK and BAX, making the D as the right answer here. BAK and a BAX. So the answer is D here. Okay, back and backs. Okay, remember whenever you have letter L like BCL, BCLXL or MCL, these all are always anti-apoptotic genes. Okay. Well, any doubts, please ask me, right? Next question. This young boy presents with joint swelling after a fall, and the lab investigation show a normal PT and raised APTT. Tell me, what have you marked for this as answer? So guys, I really want all of you tell me, so what do you think is the answer to this question? Right? Answer, please. So, the point to understand here is whenever you have a patient who has a PT and an APTT, the first way to approach this question is what do they measure? So actually, PT measures extrinsic pathway plus the common pathway. APT measures intrinsic pathway plus the common pathway. Okay, this is the first thing you should all know. The first thing you should know. The second thing that you should understand here is when you come across PT and APT is that when a patient has a raised PT and normal APTT. Okay, so what does it refer to? It refers to a problem occurring in the extrinsic pathway. And what all do you know is an extrinsic pathway? The one major thing you should know in extrinsic pathway, that is, you should know is actually the factor 7 deficiency. Apart from factor 7 deficiency, what can also be there in the problem of PT is that there can be a warfarin dosage, there can be a severe liver disease. Okay, this a warfarin dosage. There can also be a severe liver disease. Okay, and it can be vitamin K deficiency. But when you come across the increase of APTT and then you have normal PT, now the patient can have a factor 12, 11, 9 and 8 deficiency. Along with that, it can be along with that, it can be VWD, right? And it can also be to heparin dosage. Okay. Now a patient supposedly has a raised PT also, APT also. The third scenario. Patient has raised PT plus a raised APTT. Then the patient will have a intrinsic plus extrinsic pathway deficiency, which can happen surely in DIC, or can be a common pathway deficiency, which can be 10, I'll write it here, 10, 5, 2 and 1 deficiency. This is how you must approach these cases, PT, APT and the others ones. So in this case, the question is giving you a raised APT, but mentioning your normal PT. But the patient has joint swelling after a fall, right? The joint swelling cannot happen in VWD. Please understand this. Because VWD basically is a problem of the primary plug. And hence the patient will surely have petechiae purpura. It's a main problem in the VWD. It can be definitely not IDA, and as I told you, it cannot be platelet disorders because of the problem in joint swelling. Please understand, joint swelling aa gaya, it has to be a coagulation factor deficiency, and hence the possible answer here is hemophilia. Okay. Now, what is the status of the marked individuals? What is it? Tell me. Well, it's clearly mentioned here the answer though. The answer adopted from another family. So all those pedigree analysis findings you must be aware of. I'll just try to show you one from the image later on, also in the Google. Okay. Sure. A young patient has a multiple dark brown to black macules on the lips and has a buccal mucosa also black pigmented. Colonoscopy shows multiple hematomatous polyps. Okay, what is the most likely diagnosis? What do you think is the answer? Tell me. Multiple hematomatous polyp is there. Yes, देखो, when you come across hematomatous polyp, there is only two answers. One of them is a Buerger polyp, and one is a juvenile polyp. Okay, so now what you should understand here is that when you come across these as an answer, the pure sugar polyp, if you look at the site, is mainly in jejunum, and the mutation it often carries is STK11. The clinical feature it often has is a peri-oral hyperpigmentation, and in the microscopy they often show a tree-like, means arborizing pattern. Tree-like means arborizing pattern. When you come across the juvenile polyp, these polyps actually occurs in rectum, and they have a SMAD4 as a mutation. They often have a rectal bleeds, okay, and the in microscopy they don't have a tree-like pattern. Often they have large glands with mucin, okay. So in this question the answer clearly becomes because of the hyperpigmented mucosa of the buccal and the area, it points towards a pure sugar polyp. Okay, had this in FAP, the FAP would have given a history of either a hyperpigmented retina. Okay, this actually presents with retinal hyperpigmentation. Okay, Gardner syndrome will often have a finding of food. What is food? It will have FAP, osteoma, orontoma, and desmoid tumors. And Cronkite-Kanada syndrome is actually a non-inherited. It's not an inherited, so it's called as non-hereditary hematomatous polyp. Non-hereditary type of hematomatous polyp. Okay. Yes. Now, next question. What CD markers are typically positive in CLL? What CD markers are typically positive in a case of CLL? So when you talk about CLL, because it's a B-cell lymphoma which surely have 19 positivity, it may have 20, 23 and 5 also positivity. The how to remember these lymphomas, very simple way. When you talk about lymphomas, the lymphoma can either be, the whole origin points towards a B lymphoblast, which then becomes a B lymphocyte. The B lymphocyte would then become a naive B cells. Okay, naive B cells. The naive B cells will first go to the mantle zone. The mantle zone would then move to the GC area, and post GC it becomes to the post GC, and some books also call this marginal zone. From the marginal zone it comes out to become two things. One is a plasma cell and one is a memory B cells. Plasma cell and a memory cell. Now the point is, whenever they become a B lymphoblast, the marker surely will be 19, 20 and 34 positivity. They can also be TT positive. All these markers are positive. But when they become B lymphocyte, now because of B, 19 and 20 remains positive, but this time 45 becomes positive and 34 and it becomes negative. When they become naive B cells, they become, apart from the above marker, they become 5 positive. The same 5 positive go to the mantle zone. GC has 10 positive, 5 negative. The post GC has actually 10 negative and 23 positive, and the plasma cell often have 38 positivity. Now the question is, which lymphoma comes from which area? So remember, number one, that CLL would arise from two areas. One is a naive B cell and one is a marginal zone post GC area. And so the marker for CLL will surely will be 5 also and 23 also. Both will be the marker for CLL, and hence this answer here is C. But if you look at the mantle zone lymphoma comes from the mantle zone, and hence the marker is 19, 20 and 5 only. Whereas Burkitt lymphoma, diffuse large B cell lymphoma and the follicular lymphoma, all these come from GC area. Now because they come from GC area, the marker has to be what? The marker has to be 10 positivity. Okay. In plasma cells, the marker is multiple myeloma. Okay. And memory B cells, I am not getting any special marker, but remember they give hairy cell leukemia. So if you recall in this way, all the CD markers become very simplified, because the marker for Burkitt lymphoma surely will be 19, 20, 45 and 10 positivity. This is how you must remember the CD markers of all the lymphomas here. Okay. Now one question that has been put here forward by Mehdi Abbas in the previous question was, sir, this was 12 years old, but I completely understand it's 12 years old, and hence the answer anyway cannot be a juvenile polyp. The answer has to be pure sugar polyp. Okay, very good. So Now, a 2-year-old has fever, lymph node enlargement, and HNE has hallmark cells. The diagnosis of ALK was made, anaplastic large cell lymphoma. Anaplastic large cell lymphoma. So what have you marked for this as answer? It's a new question for all of you. So can you put forward your answer, what you have marked here? What is the mutation for anaplastic? It's called as T cell lymphoma. ALK positive lymphoma. What is the main mutation you marked for this? Yes, guys, I want the answer for this. Waiting, please. Answer. देखो, the answer is translocation of 2 with 5. That's a new question, completely agree to this. So basically what happens, these mark cells, they have this type of typical hallmark cell, and they're called donut cells. Donut cells. Okay, they're also called as hallmark cells. Horseshoe shape or the Dolmark cells. देखो. Now what happens is, because of T cell lymphoma, the marker will be CD3 positivity along with 30 positivity. This unique marker they have, T and 30 positivity is a unique marker for the T cell lymphomas. Now remember, these often have the most commutations translocation of 2 with 5, and 2 with 5 actually refers to the ALK with NPM mutation. They actually are referred to as ALK with the NPM mutation. Typical marker for 2 with 5. But remember, apart from this, they can also have other markers like 1 with 2, inversion 2, 2 to 3, a lot of other markers also there. But why is 2 also involved? Because on the ALK gene is on chromosome number 2. And so 2 is always involved. So if you look at the translocation, they can show, apart from 2 with 5, they can show that's 2 with 3. Okay, 2 with 3. They can show 2 with 17. They can also show 2 with 19. They can also show 2 with 22. So all but 2 are there, and how to remember 2 is ALK. Okay, the ALK actually is a 2. ALK is often in the 2. Okay. Now if you recall this question, in case you are getting confused, the problem, if you look at this question, this is actually Burkitt lymphoma, remember? In fact, this also is a Burkitt lymphoma. This is in focal lymphoma. So by exponent principle, you should get the answer. The answer should be C. The point is, in usually NEET PG FMG, you don't need to know the answer to all the question. By safe principle of exclusion, often we come to the right answer. Okay, so better you don't always look in the answer you know or not. By just thinking the other option not right, you often get to the right answers. Right? Chalo, let's move back to the main question. नॉन हॉजकिन भी था सर, मतलब पंकज कुमार किसकी बात कर रहे हो? नॉन हॉजकिन कहाँ था? इस वाले में था, इस वाले में था नॉन हॉजकिन्स। एक काम करता हूँ, नंबरिंग कर देता हूँ पहले क्वेश्चन नंबर. सो टिल नाउ दिस वन इज क्वेश्चन नंबर 1, दिस क्वेश्चन नंबर 2, 3, 4, 5, 6, 7 एंड नाउ मूव टू क्वेश्चन नंबर 8. चलो, तो पंकज किसकी बात करो, क्वेश्चन 7 में या 8 में? कहाँ पर था नॉन हॉजकिन लिम्फोमा? चलो, क्वेश्चन नंबर 8. A young boy presents with a history of ingestion of paint chips, leaves and soil. The blood examination is conducted and now the patient has some environmental exposure. What is the most likely diagnosis? This arrow has been shifted though, but look at this one. What is it? It's a basophilic stippling here, right? It's a basophilic stippling which occurs due to lead poisoning. Okay, it occurs due to lead poisoning. पंकज ने 6 भी बोल दिया, 7 भी बोल दिया, या तुमने कंफ्यूज कर दिया मेरे को. ठीक है, तुमसे बात करता हूँ. दिस आंसर इज lead poisoning which can show this type of issues. In iron deficiency anemia, often you get a history of microcytic hypochromic RBCs. They can be target cells and they can also be pencil RBCs. Okay. In thalassemia minor, we often get micro hypo RBC only, nothing else you see there. In hemolytic anemia, often you get different type of hemolytic anemias. You can often get but high retic count, but then there can also be a cystocytes, it can be a fragmented RBCs, it can be polychromatophils, so it can be spherocytes. So those type of RBCs seen in a case of hemolytic anemia. This typical case of a history of a paint chips, leaves and soil, and now the patient actually has lead poisoning here. Okay, clear hai? Chalo, let's now move to question number 9 here. Answer, please answer this question. Yes guys, answer. अच्छा 7 था सर, क्वेश्चन में नॉन हॉस्किन दिया था. अच्छा ओके, डायग्नोसिस ऑफ एनाप्लास्टिक नहीं लिखा था, ये नहीं लिखा था ना, तुम कह रहे हो नॉन हॉस्किन लिखा था, राइट? इसमें नॉन हॉस्किन लिम्फोमा लिखा था. ठीक है पंकज, आई करेक्टेड, थैंक यू डियर. ओके यस, इसका आंसर क्या होगा? इट कैन बी स्क्वामस टू इंटेस्टिनल कॉलम एपिथेलियम इज द राइट आंसर. ठीक है, तो देखो दिस इज एक्चुअली अ बैरेट इसोफेगस, and if you recall, the Barrett esophagus actually has a hallmark of, it has a hallmark of goblet cells, because goblet cell is a typical cell of intestine and hence it becomes a hallmark of intestinal metaplasia. Okay, that is what is referred to as Barrett esophagus. This actually is a pre-malignant lesion, if you recall, and this can lead to adenocarcinoma in situ. Ultimately it can lead to a frank adenocarcinoma. It can lead to frank adenocarcinomas. ठीक है, चलो क्वेश्चन नंबर 10. Bernard Solier is caused by defect of which of the following glycoproteins? So who will tell you the answer to this question? Tell me. Bernard Solier बताओ. Is caused by a defect in which of the following glycoproteins? Yes, it's 1B9. Very good. It's 1B9 complex. Very good. देखो 1B9 and 2B3A. देखो 2B3A cause Glanzmann thrombocythemia. 1B9 cause Bernard Solier syndrome. Now remember one thing, that when you talk about endothelium, that is a vessel. Okay. Now in the vessel, these are the broken endothelial cells like this. Okay, and on them is a protein by the name of von Willebrand factor. On this is a platelet, this one, by a molecule GB1B9, glycoprotein 1B9. Okay, then the second platelet would be actually attracted on the first one, and these two are glycoprotein 2B3A. Okay, what is between them here is a von Willebrand factor. Von Willebrand factor like this. ठीक है, अब remember, if the patient supposedly has a problem in, okay, this can also be fibrinogen. Remember, it can also be fibrinogen. So if a patient supposedly has a VWF defect, it can be von Willebrand disease. 1B9 is Bernard Solier syndrome, and 2B3A is Glanzmann thrombocythemia. Okay, so among them, remember, the most common is VWD. This also you should remember. Secondly, a Bernard Solier syndrome often have large sized platelets and also have thrombocytopenia. This is also what you should basically remember, because a lot of questions can be asked on these topics as well. Okay. Question number 11 बताओ. A child has a renal disease. Undergoing biopsy, on congruent staining, the deposit shows apple green by refulgence under polarized light. The following is the most likely diagnosis. What have you marked for this answer? Please, guys, all of you, tell me the answer to this question. Very good. Pankaj, एकदम form में हो. Very good. It's amyloid. The patient basically has a apple green by refulgence under polarized light. This typical history is pointing towards amyloidosis. देखो, minimal changes in light microscopy will have no change. The only change you find here is in electron microscopy, and that is called as, yes, it is called as effacement of foot process. Okay, we call this effacement of foot process podocytes. Diabetic nephropathy has multiple findings. I can write 5 findings here, and the findings mainly will be Kemmel-Steele-Wilson lesion. Okay, and it can be a diffuse, because Kemmel-Steele-Wilson is what, nodular, right? It's a nodular, but it can also diffuse mesangial proliferation. So either it can be a nodular proliferation or can be a diffuse mesangial proliferation. Okay, in the membranous it can show a spike and dome appearance, and along with that it often shows podocyte effacement. Just like the minimal chain disease, this also shows podocyte effacement. This is how you can explain and differentiate these two diseases. Okay, so very good, Saeed Zain also, thank you. The answer is here, I wrote very clearly. Okay, chalo, question number 12. A patient has headache, visual disturbances, and hypertension. There is cerebral hemangioblastoma, abdominal aging shows multiple cysts in kidneys, along with solid renal mass, and is associated with RCC. So this patient also has brain tumor, a similar history. Father had a similar history. And what do you think is the main problem here? So can you tell me which syndrome is this whole thing talking about? The main basic findings are headache hai, visual disturbances hai, and has hypertension. 3 problems are there, right? Along with that, there is cerebellar hemangioblastomas. Okay, abdominal imaging shows multiple cysts in the kidneys with a solid renal mass. So what are these all thinking about? Very good, Pankaj, very good. It's von Hippel-Lindau. Okay, it's basically a von Hippel-Lindau syndrome. It's a chromosome number 3p. Now how to recall this? A simple recall this is Hippel. Von Hippel-Lindau syndrome. So we can recall this as actually Hippel. What is Hippel, dear? Hippel stands for hemangioblastomas. So hemangioblastoma actually refers to CNS, eyes, and lung. So this last two is this eye cyst and the lung lesions. This eye is increased risk of RCC, to be more precise, clear cell RCC. The first P is pheochromocytoma, and the second C is Port-Weinstein. Second P is Port-Weinstein. So this whole thing points towards what is referred to as Hippel. Von Hippel-Lindau syndrome. Okay. So answer is what? 3P, not 3Q, it's 3P. Okay. Next one. A newborn presents with upward slanting palpebral fissures, Chinese eye appearance. Here they go. Okay. And has a flat facial profile with a hypotonia. And what is this basically talking towards? Yes, it's basically a history of cry-do-chat. It's a very simple question, right? Cry-do-chat syndrome. Cry-do-chat syndrome. Okay. It's basically a cry-do-chat syndrome. This is question number 13th. Question 14th. Hereditary non-polyposis colon cancer, HNPCC, is also referred to as Lynch syndrome. Okay, so which mutation causes Lynch syndrome? Tell me what is the answer. So APCC causes what? Okay, which mutation? It has a APC mutation. Okay, MSH is the answer here. MYC is actually involved in CMYC in Burkitt lymphoma, and TERT is actually for the multiple mutation. Actually TERT is involved. One of them is the telomerase activation, and telomerase activation is often seen in malignant melanoma. Here the answer is MSH and also one MLH. So MSH MLH is actually क्वेश्चन 13 में इनडायरेक्ट वे में था. ओके, क्या बताओगे पंकज एग्जैक्टली क्या क्वेश्चन था? तो थोड़ा आई कैन एक्सप्लेन यू देयर, बट आई थिंक दैट्स इफ इट चाइनीज आई दिखा हुआ है, बाई प्रिंसिपल ऑफ एक्सक्लूजन यू गेट द आंसर ऑफ cry-do-chat syndrome. ओके, चलो, दिस इज क्वेश्चन नंबर 15 नाउ. A 25-year-old woman has lower abdominal discomfort and post-surgical image of this is falling shown. What do you think it is? Answer this question, guys. अच्छा 5P नॉट मेंशन. हाँ ठीक है, इसमें मेंशन था क्या? अच्छा ठीक है, दिस वाज नॉट मेंशन. ठीक है, ओके, एग्रीड. So anyway, this one is what? It's a case of mature teratoma. देखो, if you get a case of serous adenoma, there's a large cystic lesion, and often the patient will have ascites. I'll show you a abdominal caking. Okay, caking. Business adenoma can have a peritoneal adhesions, but can also have a history of caking. To differentiate these two, often look at CA 125. It is very, very high here. It's almost raised to normal here, 125. This is how you differentiate these two diseases. Endometrioma is nothing called as endometriosis. Endometriosis hota hai, which basically has a endometrial glands outside the endometrium. Okay, here the answer is C. FBN gene mutation, this is question number 16, sorry. So FBN mutation is seen in which of the following genetical disorders? Answer. Yes, Marfan syndrome. A symbol remember Marfan's is also Marfan's, right? Is mitral wall prolapse. A is aortic aneurysms. Aortic aneurysms can also be dissection of the aorta. It can be retinal detachment. The main problem is the question here, fibrillin, that's a FBN mutation here. A is arachnodactyly, is negative nitroprusside test, and that is superotemporal subluxation of lens. Along with that, there's skeletal changes. Superotemporal subluxation lens with skeletal changes are the basic finding here. The other is Marfan syndrome. Okay, it's multiple times. In fact, the same question was also asked in this year, NEET PG. Exactly the same question was asked also. Okay, now we move to question number 17. A newborn is noticed to have a single transverse palmar crease. Single transverse palmar crease, what is semen crease, right? And semen crease is seen in, yes, the answer is Down's syndrome. Okay, semen crease is often seen in Down syndrome. Okay, about the other options here, the Patau syndrome is very same as Edwards syndrome, and I call this many times in my classes also. The Patau's and Edwards is very same. How to remember this Patau's? Patau's ko often recall this as Rocky Mountain. Rocky Mountain with the rocker bottom foot and there is a overlapping fingers. That's very two important features here. But problem is in the Edwards syndrome, you can also get the same finding, but you also get polydactyly and you get undescended testis and a small penis. This is how you often get in Edwards syndrome. You can differentiate them by the Patau syndrome actually. Okay. Chronic smoker who worked in cement factory for past 20 years has called mesothelioma, and you all remember it is actually due to asbestos. It's a simple question. Asbestos exposure often leads to mesotheliomas. Okay, mesotheliomas. 19. This pap smear was done, and what is the best way to fix this actually is 95% formalin. Remember, we don't use 50% formalin anyhow. We use 10% buffered formalin is the most common and often used in tissue fixation, but this one is in pap smear. But overall, the most common is a 10% buffered formalin. Buffered matlab you have to maintain the pH of this and has used the but buffered. Okay. This is 1920th. Blood transfusion reactions is done by which type of hypertension reaction? Because blood transfusion often what is antibody mediated, and antibody is all about type 2 hypersensitivity reaction, right? So all the antibody is basically a type 2 hypersensitivity reaction. Remember the type 1 has 4A. 4A matlab asthma, allergy, anaphylaxis and atopy. Along with that urticaria and the hay fever is type 1. Type 3 is sharp. Sharp means SLE, serum sickness. This A is Arthur's reaction. There is R is rheumatoid arthritis and P is polyarthritis nodosa. That's a pattern. Okay. Type 4 has all granuloma as example. With non-granuloma, it can be type 1 diabetes, it can be a multiple sclerosis, and can also be a tuberculin reaction with contact dermatitis. The 4 other reactions apart from granuloma, which can be type 4 hypersensitivity reactions. Okay. So here are my questions that I recalled from 20 questions I got from pathology point of view, which I think is fair enough, and we expect this question always in NEET PG and ICT also along with the FMG. In case you have any doubts, please let me know what problem, or in case you need any doubts, you can please ask me right now in the live group. I'll surely be answering this right now. I'm giving you 2 minutes in case you want to any just put forward any doubts. You please ask your doubts clearly to me as well right now. Okay. लेप्रा से रिलेटेड क्वेश्चन था सर. लेप्रा देखो, लेप्रा रिएक्शन का अगर क्वेश्चन होगा तो मेनली डर्माटोलॉजी ने डिस्कस किया होगा सर ने, बट अगर लेप्रा रिएक्शन की हाइपर सेंट रिएक्शन थी तो लेप्रा रिएक्शन टाइप 2 इज टाइप 3 एंड टाइप 1 इज टाइप 4. आपको सबको याद भी है, दिस बेसिकली द क्वेश्चन एक्चुअली बीइंग आस्क्ड. ओके, so guys, that's all for the night. I am very sure that your exam might be well and you're doing this exam much better, and I'm very sure that most of you and many of you will pass with flying colors and make us all proud and happy of all our achievements. Till then, goodbye, God bless you all, and good night to all of you. Okay, take care, bye bye.